What would be your take on ARNI, sacubitril valsartan, in patients of heart failure with CKD? Because it is a common question, right? Today we know that most of our heart failure patients will have a little bit of reduction of GFR or maybe even a gross CKD, right? And it's so difficult to treat them because the first question that the physician asks or our resident asks is that below how much of GFR is ARNI contraindicated, right? And in fact, the real challenges of ARNI, this excellent drug, is just three. One, hypotension, second, hyperkalemia, and third, low GFR. So people are stuck there. GFR of 40, 30, should I give, I will not give, so the patient doesn't get that benefit. So would you please tell us your opinion, because we value it so much. Dr. Satish.
Yes, thank you, Dr. Taini, and very nice discussions, all of them, and lovely talks also. I'm really glad to be part of this forum. So about CKD, I think if you look at that, CKD patients are generally discriminated against. They are not part of clinical trials. If you study any new drug, they will exclude CKD patients. If you study any new methodology, exclude CKD patients. Even primary angioplasty was not given to CKD patients for such a long time because they say creatinine is high and then you don't want to do a primary, kidney will become worse, etc. And some patients also go overboard. They say my creatinine rise, I don't want anything to do with it. So it's more important than. So it becomes a problem. But I think if you look at it, you should consider CKD as part of general population. If a patient has FRF and has CKD, that patient should be on ARNI. So I generally take over because whenever the cardiologist comes to the refers the patient to creatinine of 2, if they have not started on ARNI, I start on ARNI and I follow up with the cardiologist also. We follow up together. So the problem is, of course, hyperkalemia. The hyperkalemia is actually generally less with ARNI than if you give, say, enalapril or ARBs. So if you're giving telmisartan or something like that, and the hyperkalemia is actually more with that. So ARNI is actually better in terms of hyperkalemia, considering, compared to its other equivalents. And the thing is that patients with CKD, actually, I find they benefit much more than other. I've seen some miraculous recoveries in patients with CKD. They are recurrent admissions, pulmonedema. You start them on ARNI and it's like magic. The entire thing vanishes. They become completely fine. They're settled in. And a patient who was on recurrent admissions for 6 months has now been following 4 to 5 years without any problem. Their creatinine was going up every time. They started from 2.5, gone up 3, 4, 5, etc. Has now come back down to 2.5 to 3 and is remaining stable. So kidney function also stabilizes with ARNI. So you must understand that initially it may go up. The only thing is that probably we should have a discussion with a nephrologist, and in combination with nephrology and cardiology, we should sit together and treat the patient. That's the only way to do it. But definitely the benefits are there, and not only that, we have got a new study from Trivandrum itself, studying the use of ARNI in dialysis patients, and we have shown that patients who have some urine output, of course, if they have no urine output at all, sacubitril, I don't think it is going to be of any effect. But in those patients with dialysis and who have residual renal function, definitely there is a benefit with ARNI in those populations also. So even up to dialysis, we can continue. There is no subset of CKD that you cannot give ARNI.
Excellent, excellent. I think that fully agree with that. That ARNIs are not just that. It is those patients who tend to develop dips like hypotension initially or dips in GFR initially are the one who are going to benefit maximal in the later part. And they don't have more events. They have clearly shown that the dippers don't have more events. So don't be afraid that, oh, my patient blood pressure was 110. I started ARNI, now it is 95. I mean, that is the patient who would eventually pick up, and exactly like Dr. Satish said, that why come and thank us with their life, that he has become so much better and all that. So I think ARNI is an integral part, and even when the same thing was said for SGLT also, that okay, the GFR is so low, how is SGLT going to act? We are not looking at mere reduction or improvement of kidney function. We are talking about, see, the kidney patients all die of heart, right? They have a MACE or a heart failure hospitalization or die of heart, right? And that would be prevented by ARNI and SGLT inhibitors. So I think it's an integral part. Thank you, Dr. Satish, for elaborating on that. Do we have Dr. Dilip connected?
Sir, no, some emergency, so he is not there.
Okay. Okay. So do we have questions, anything from the attendees?
Yeah, sir, one question from the attendee is about the Dr. Pramod Kumar sir showed about the co-crystalline technology which is there in the ARNI, in the innovator Azmarda. And so can you just focus more on this, what's it's important in a clinical patient? So can you please share your views?
Yeah. Dr. Pramod?
Muted.
Yeah.
Sir, you are muted. Dr. Pramod, you are on mute.
As I mentioned, it's a combination of two molecules, that is sacubitril and valsartan, in a equimolar ratio, 1:1. And when you combine both these things, there is a co-crystallization, and there are certain properties that are very important when you use this combined crystal. And they have to be studied by X-ray and other molecular features. And if they are satisfied, I think the benefit will be equal to the molecule that is given by the originator. And this compound, because it is purchased from other sources, it may not fulfill these criteria, and therefore a original molecule is important to get the complete benefit of the molecule, of the drug.
Yeah.
Okay,
Thanks.
let me add up a little bit on that. See, the point is that this is not very clearly, this is not an advertisement of any brand, including Azmarda. We are not talking about that. All we want to impress upon you is that in this particular medication, Arni, it is extremely important as to how it is manufactured. I will tell you the reason why. See, years back, we had multiple NEP inhibitors, like omapatilat, we had candoxatril, we had ecodatril, we had acetoorphan. But theoretically, yes, they all increase BNP, CNP, ANP, bradykinin, adrenomedulin, but there was no benefit in mortality or reduction of cardiovascular events. And that is a time when we learned that if we block NEP, these NEP inhibitors increase angiotensin II. So you'd get benefit only when you supply an optimal amount of angiotensin II inhibitor like an ARB piggybacked on a NEP inhibitor like your sacubitril. So then initially we all asked that why don't you have two pills, one of sacubitril, one of valsartan, and eat it. It doesn't work. So it is a very complex lattice of co-crystallization that seems to work. And all that Dr. Pramod has shown is that not everything is similar. So you need to choose carefully, right? So it is exactly like low molecular weight heparin or a biological product, where unlike a tablet of paracetamol, whichever company you buy, this may not have similar efficacy as you expect. So be careful when you choose a brand. That is all about it. Because each one seems to be, see, this is beyond the purview of a physician. We have very little knowledge about how Dr. Komal is involved in manufacturing. But it looks like each one is different. I mean, that is take home just that. Each one is different. And so if one is different from the other, maybe their actions and their event rate reduction might be different. That's all about it. Any other questions coming in?
Yeah, thanks, sir. So the next question is about how to maximize the dosage of Arni in clinical practice. We feel it difficult to go to 200 mg. So your suggestions on that. So anyone can.
I think anyone can. Dr. Subhash Chandra, Dr. Pramod, Dr. Prashant.
I
Anyone?
think general.
Yes, sir. So in my practice, I try to maximize so I say that the maximum dose of Arni is the maximum benefits equivalent to. Otherwise, maximum tolerated dose of Arni is the alternative. And at times, patient comes with 88 systolic blood pressure, 90 all, and it coming walking. And then there are so many offline thing. I do 50 mg, half Azmarda, half BD, or something like that. So many tips and tricks. But I strive to endeavor to put to 200 BD, the guideline directed dose, many of my patients, but which is always, and there are so many, you have to remove diuretics, you have to remove a non-essential drug, nitrates and other antihypertensive and CCBs, and so many tips and tricks. And you have to be good erudite internist in order to risk assess and dynamically triage the thing in order to accommodate these disease modifying drugs and so that's the right question. You have to be on the highest dose, but it's not always possible. Tiny sir, Subhash sir.
See, I think, this is basically our inertia, which is again understandable. See, let's say a patient, all of us have started on Arnis, let us say 50 milligram twice a day. Okay. And he was ill in the ICU and all that. Over time, he has improved. We have convinced him to take Arni. And now he comes back for follow-up. How are you doing? Sir, I'm doing excellent. I'm going to school, taking class. I'm a teacher. I'm back to class. I am fine. Excellent. Thank you, sir, so much. Right. Now, this patient, he is doing well. So normally, it is our inertia where we would say, okay, 50 he is fine. Why should I go and make it to 75 or 100? Right. Unlike a thyroxine, or we don't have an, okay, if he had shown us a BNP And if I'd seen that his BNP is still 2,600, I would have said, no, there is something wrong, you increase it. Or if he had come with an echocardiogram which showed that previously EF was 45, this time it is 40, I am sure to increase the ARNI. But what happens most of the time is clinical common sense. He comes and says he's fine, everything is fine. And we don't feel like increase, but understand for every one of us, again, relearning that we should go to the guideline-directed medical therapy dose to get maximal benefit. But there's a small caveat. See, here, we should not feel shy that my patient is on 25 BID. JACC had published last year a cohort where, in a real-life data, it's 850 patients. They divided them into 3 groups on the dose of ARNI they were on. I think the lowest dose was 113 milligrams daily. Second dose was some 220, and third was about 400. And they showed that if you look at their ejection fraction, their end-systolic dimension, their end-systolic volume, and their NT-proBNP, everything reduction degree was same, 20%. So, not that is not to tell us that don't go to maximal doses. Do go to maximal doses to get the full benefit. But at the same time, even if you are given a small dose, don't be shy to admit it, because even that would have done good to your patient. Dr. Subhash, any comments?
Yes, sir. I completely agree with both the views. And in Indian practice, we have seen, though we don't have access to 25 milligram tablet, yet in patients who have very precarious blood pressure levels, we do give breaking these tablets into half morning and half evening. And believe me that if they tolerate this dose, the patients come to a level where they could even tolerate 50 mg, and then from there on, we can escalate it to 100. But we should strive hard, as you rightly said, there should not be inertia in escalating the dosage. We should strive hard to give them 200 BD. And if I share my experience, maybe 40% of my heart failure patients, HFrEF patients, are tolerating 200 twice a day tablet, and another 30% would be tolerating about 50 BD, and rest are on 100 BD. That could be the split of the patient which I see. And keeping a close watch on the potassium levels, because sometimes these patients have cardiorenal syndrome, and of course blood pressure levels. We should try to escalate all the 4 foundational pillars. In SGLT, the best part is that you just one dose and you're done with it with very robust benefit. And of course, MRA along with ARNI, one has to be cautious looking at renal functions and the potassium values.
So next question, up to what creatinine level should I start ARNI in my patients? Creatinine, potassium, and the eGFR. That's the question.
Dr. Satish, should you take it up?
Yeah, definitely.
Already.
Yeah, so already I think I partly answered that question. So there is no level of creatinine at which we would not start ARNI in any patient with HFrEF. Definitely there. Potassium is a different story. So generally what we do is, if the potassium is high, I mean 5.5 is my cutoff for saying high. 5.1, 5.2, I'm not really bothered. So if it is more than 5.5, probably we will try all measures to reduce the potassium. Say put him on Lasix or something like that, put him on a low potassium diet and all that. I don't usually use the potassium binders that much because they are difficult to tolerate and they have a lot of toxicities and they're not very effective. There are newer potassium binders which are not yet available in our country, which may change this. But right now, our potassium binders are not very good. So it is not good for long-term use. Short-term use, it is fine. For long-term, it's not good. So that is the way I would do. So if the potassium is very high, then probably I would not be starting the ARNI because it's too dangerous. But if the potassium is up to 5.5, I will start and I will follow up and take all measures to reduce the potassium. So that's the answer to that question.
But I think as the newer potassium binders come in, probably the whole scenario would change. Because in US, definitely. I was talking to a few cardiologists. Their standard protocol is that they put the patient on a potassium binder like Localma, and then add up Fenolone and add up sacubitril valsartan and everything kind of thing. They say, oh, nothing will happen, and they tolerate it so well. So preemptively you add up. There is
data. There is now data that those people who are not tolerating ARBs, especially in CKD, and in those who are not tolerating ARNI in heart failure, you add this potassium binder, and they have their mortality improves because you are adding this molecule, which is definitely effective for them. So that will definitely change the practice. The only problem is that when these come here again, the cost will be prohibitive in the initial stages. So
the combination
that's probably one of the reasons why ARNI take-up is also not so great.
So
Combination
aren't
of
SGLT2
SGLT2
inhibitors are RAS inhibition facilitators? Like if we have SGLT2 inhibitors on board, so this is a realm where I think RAS inhibition or MRA to some extent are accommodated well, because their tendency to blunt the downhill trajectory is more vis-a-vis SGLT2. Of course, they all are the four are hard outcome improvers. So SGLT2 inhibitors on board, and then we have a good leeway to accommodate, make them go inside and have a good commodiousness. Is this a tip and trick?
There was a paper in JACC which showed that with SGLT on board, your chance of achieving a better dosage and patient tolerating an ARNI and an MRA is far better when SGLT is on board. That is well known. That is well known. The chance of hyperkalemia would be less, perhaps.
Lesser, yeah.
Add to that, there is some data also showing that SGLT2 inhibitors will also mitigate the potassium rise.
Yes,
so it may be useful that way also.
Yes, yes.
So it's a good, sir, Dr. Satish, sir, that you're saying at any level of EGFR, or so you said that you went to stage 5 ESRD or stage 4 is no hindrance here. But unfortunately, I should be saying in a very harsh words, many nephrologists are still very fearful. We somehow build up and they stop at EGFR 30, 35, scaring patient, and they're not aware there's something called heart exists up there. So this is and good that it's coming from you as a nephrologist and all, Dr. Tiny, sir, Subhash, are all super QS of India whom we follow. This is very important. If all the people are the delegates, eminent people who are listening, this is very important.
One important addition, which I think should have come from Dr. Satish, who's a nephrologist, is that one has to go deep into taking history that what kind of salt are these patients consuming. So a lot of these patients, in order to reduce their sodium content, would resort to taking, Sendha namak, Kala namak, and all those kind of low na and low salt things. And that is a big culprit in causing hyperkalemia also, besides having these drugs on board. And of course, consuming a lot of fruits or juicy items or coconut water, banana, all of this could lead to hyperkalemia, which should be struck out from their diet. And of course, looking at all the aspects. The second aspect is that between the ACE inhibitor hyperkalemia and ARNI hyperkalemia, I think ARNI hyperkalemia is much less lethal as compared to the others. And SGLT, of course, on board does some trick to let it be tolerated well. So that is how we manage the potassium story.
G.
So next question, can I take? It's about the
last question. We can take the last one.
Yeah, I'll take the last one, sir. This is regarding diagnosis of HF, especially HFpEF, where how your tips on early diagnosis, because where these people miss. So your tips, your insights on this diagnosis part.
Yeah, Dr. Satish, Dr. Subhash, you want to take it?
Yes, sir. So diagnosing HFpEF is an art. One has to take history that any obese person presenting with dyspnea whose echo-LV ejection fraction seems normal, and you don't find a pulmonary cause, one has to order an anti-proBNP and ask your echocardiographer to comprehensively conduct the diastolic function of these patients. And that is how we arrive at a diagnosis. Besides this, there have been a lot of pointer systems where HFpEF pointers could give you the score and one can easily diagnose it. There'll be rare instances one has to resort to doing invasive studies in these patients where one can measure pulmonary artery pressure or the exercise hemodynamics in cath lab. And all those have been enlisted when it comes to diagnosing HFpEF, but one needs to really strive hard to diagnose HFpEF before instituting these therapies.
Oh, perfect.
Yeah. So now I request Nair sir to please give the concluding
So thank you, everyone. I think we had a fantastic learning session. First of all, we learned about the breaking news from ESC, and where we clearly learned a couple of things. Dr. Subhash Chandra taught us that number one, in HFrEF, ARNI rules. Yeah, ARNI is the best in HFrEF, and it forms clearly a part of the 4 foundational therapies, and you have to institute ARNI. You have to be careful that you are going to the highest possible tolerated dose to get the maximum benefit, in addition to the other 3 of SGLT inhibitor, MRA, and beta blockade. That is point number 1. Second thing is clearly showed that the data coming out shows that there is no stable heart failure, right? Any heart failure patient, see, understand that a heart failure patient who is in class 1 has the highest risk of sudden cardiac death, right? So there is no stable HFpEF. HFrEF. Anytime he gets one hospitalization, his situation worsens and the downslope goes far more steeper. And the third thing he taught us about the upcoming concepts of HFpEF, whereby there are so many phenotypes. There could be an obese, metabolic, abnormal person. There could be a thin, elderly gentleman with AF. There could be somebody with a CKD, or there could be somebody who has a very severe LVH, like an HCM variant. So, it's a different phenotype, and we need to choose carefully as to how we apply our therapy. Dr. Pramod very carefully and very nicely showed the burden of heart failure in India. The Kerala Heart Failure Registry, the Indian registries, and how important it is to treat them properly. And he also showed that how the available brands, how they vary in the market, right? Their co-crystallization techniques probably is so different that each one shows different characters. So they are not same. So we need to choose carefully. And, in the question and answer session, we learned a lot of things. We learned that, and again, let us re-emphasize that what Dr. Satish said, that any GFR, don't refuse the patient or don't deny the patient the improvement that he might get out of ARNI for his heart failure, right? So even if his GFR is low, he's on dialysis. Like he said, the paper shows that ARNI, they tend to benefit. How they benefit? By reduction of cardiac event, not the kidney, which has already been fried up. So that is not the point. So I think we had a fantastic discussion. We learned a lot. And thank you, Dr. Komal, for organizing this. Thanks, JB Chemical, for bringing everyone on board. And with that, good night. And maybe Dr. Komal will arrange for such symposium shortly, and we can interact and see each other sometimes. Thank you.
Yeah, thanks, sir. So on behalf of JB Pharma, I would like to thank all the esteemed panelists for sharing your expert insights on this complex subject of heart failure management. Thank you all. These are very helpful for all the physicians for managing HF in day-to-day life. Thank you, sir. Thanks a lot.
Bye.